All right, it's 12:30 and I know people are going to continue to join, but I might start the meeting now and first start by acknowledging the traditional owners of the land on which we're meeting today, which for us is the Wurundjeri people of the Kulin Nation. We pay our respect to their elders past and present and emerging. So welcome everyone to this NCIC showcase. It's really exciting. We have a lot to get through this afternoon. We have a lot of presentations from all our great researchers. And this is the first time we've actually put it all together in one intensive series of presentations. So each of the presentations will be very short and to the point. And then later on this afternoon, as the NCIC, we'll reconvene and talk about our future directions. But I think it's really good to hear all together the totality of the research that's being done and the breadth that's being led by our researchers here. So I will give a little bit of an introduction now to talk about our rationale. And as you all know, I'm sure I don't need to convince you, infection is a leading cause of problems in cancer patients. We know that its prevalence is actually quite high, and this is data from Jake Valentine, who is supervised by Leon Worth here, collecting data from discharges of patients at Peter Mac and looking at those that were coded with having an infection as part of their admission. So we can see that in the hematologic malignancies, it's up to 67% of patients, oncology 29%. And from our work with Jason Tribbiano, we also know allergies are quite prevalent. Antibiotic allergy is recorded in about a quarter of all our patients. And of course, this infection has follow-on effects such as increased length of stay for our patients and increase in their ICU stay. It also adds to the cost, and we know that, for example, sepsis can cost between $33,000 and $62,000 per patient with sepsis, and that's work led by Kaz Thursky. And we also know the cost of a fungal infection is really significant, and that infection is a leading cause of death after an allogeneic stem cell transplant in the first 100 days, and actually is a major cause of death in other patients' populations as well. And we're faced with the difficulty that we have poor precision in diagnosis currently. We know about the harms of antibiotics, so we try and limit our antibiotic use, but we also have a burgeoning area of new cancer treatments where we actually have not a very good handle on what the risk of infection is and when we should and shouldn't be using antibiotics. And we don't have any national surveillance data. So these are the problems that we're aiming to tackle to improve the management of infection in our cancer patient population. Next slide. So just to give a little bit of background about how it all started, we established the Department of ID here at Peter Mac in 2000. And a lot of work was done by our team, including Kaz Thursky and Leon Worth and our registrars, and building up a research portfolio over that time until in 2017 we were awarded our first CRE. After that followed a Synergy grant, and then I was appointed as Chair of Infections in Cancer and Transplant at the University of Melbourne in 2023. And in 2024, we were awarded a second CRE. And this CRE now is really moving into the digital health space and is really looking at digital solutions to many of the problems that we have identified. Next slide. So who's in the team? I think everybody knows that Kaz Thursky, Prof. Karen Thursky, is lead of our implementation stream, and Associate Professor Leon Worth is lead of our surveillance stream, as well as being in lead of infection prevention. And of course, Prof. Thursky is also Director of Health Services Research as well. So next slide, please. So I guess we see ourselves and the peak body for new knowledge and for training in infections in the immunocompromised host, with a special emphasis on infections in cancer. And so the National Centre was established after our first CRE to look at ways of improving the outcomes and the diagnosis, the management of infection in cancer. So we're really, through our synergy grants and our CREs, we're really a multidisciplinary national network. And our focus is increasingly now on digital health solutions to address the problems, the many problems that we've already explored in our patient group. So looking to find smart solutions and sustainable solutions, and those kind of solutions that can be applicable across the nation and beyond. So next slide, please. How our links are fairly well established internationally. We have our weekly meetings, which attract people from around Australia, New Zealand, Singapore, and we'd like to expand that network outwards. We have a YouTube channel where we record our monthly seminars and our symposia, and some of our symposia have had massive views on YouTube as well, particularly the COVID symposium and the one on fungal infections were highly popular to be viewed on YouTube. We have a website, we have our Twitter, we are now moving more towards LinkedIn to communicate with people in our network, and we've got a number of website visits per year as well, where all of our information and programs are listed on our NCIC website. Next slide. So when we look at our impact, and we'll hear more about this throughout the course of this afternoon with all the great presentations coming up, but we've been very successful in publications, in leading clinical guidelines, in attracting grant funding, and in changing practice. And some of the work around allergy, sepsis, vaccination, led by Associate Professor Ben Tay, and of course the children with neutropenia and fever work led by Gab Heusler, have really changed practice and still changing practice. We have a number of active clinical trials, which you'll hear about, and a large number of PhD students completed or underway at present, and are really working to broaden our scope of PhDs, including nursing and pharmacy PhDs. As well as science background and statistics and data. Next slide, please. So our achievements, I won't go on too much, but we have been successful in a number of large program grants, our project grants, looking at fever and neutropenia in children, looking at antifungal stewardship, looking at smarter ways of doing surveillance, and looking at a randomised trial of interferon led by Associate Professor Michelle Yong to look at prevention for COVID, and of course the work again with getting patients home earlier by Gab Heusler. And then, of course, we've had a number of individual investigator grants in our department as well. Next slide, please. Changing practice guidelines has been something that we've really focused on, and we're just about to have the febrile neutropenia guidelines, which haven't been updated for many years, published under the leadership of Abby Douglas and Karen Thursky. And we have authored a number of guidelines, including the fungal guidelines, which are very widely accessed. And when we look at who's accessing them, we can see it's a very international group of people, over 170 countries, and with our top access being China, followed by Australia and then the USA. But many of our neighbouring countries also accessing our antifungal guidelines, and I expect it will be the same with the febrile neutropenia guidelines. As for the pathways, I mentioned the sepsis pathway led by Professor Karen Thursky, the allergy delabeling, and so there are a number of pathways which you can find on our website, which have actually changed practice. Next slide, please. And new knowledge is something that we're always looking to develop. And I guess just two examples of that would be the Pippin study and the work on PET-CT for a diagnostic tool and a management tool for infections, led by Abby Douglas, and of course the interferon spray led by Associate Professor Michelle Yong to improve prevention of COVID in conjunction with other interventions in our cancer patient group. So these are very innovative programs, and you'll hear a lot more about the innovations today in more detail. Next slide. Workforce development is also something that we have focused on, particularly since we got the Synergy grant, and that was a large component of the Synergy grant to develop the workforce. And with the leadership of Kaz, we've developed the first AMS nurse practitioner, first accredited career pathway for a nurse practitioner in stewardship, and Belinda Lambros is now going on to a PhD, having been our first nurse practitioner. We have 2 visiting international fellows a year with clinical and research pathways that they can follow. And that's been highly successful in broadening our international links and profile. We've had many visits from many countries, including a delegation from Taiwan to look at our clinical trials setup. And I think the establishment of our own lab and trials team has been a major win for us. It's a really essential part of everything we do, and you're going to hear more about that today from our clinical trials lab and team. And then our education committee works very hard with our weekly meetings, our research meetings, and a yearly symposium, which is usually very highly subscribed. And of course, establishing our pathways, career pathways for our pharmacy and nursing colleagues is also a key outcome and goal of our group. So next slide. I think that leads me on to the final slide now. And I'm going to hand over to Dr. Megan Crane, who probably needs no introduction, but she does keep a little bit of a lower profile. So I might just give her a brief introduction, that she's the manager of our ID team, our research network, and our CRE. And Megan has really been instrumental in developing our research programs, budgetary oversight, administrative oversight, and also a lot of intellectual input into our grants and our programs. Megan has a background of laboratory PhD, and so she was really essential to develop our laboratory as well. And I think, you know, Megan has really taken on a broad oversight of all aspects of our NCIC, and I thank her very much for that. So I'll introduce her now. Over to you, Megan.
Thank you, Monica. I wasn't expecting that. That wasn't in my scheduled timetable for this meeting. Thank you. I'm going to hand over now to Zoe, who is presenting on behalf of Professor Leon Worth, who is the surveillance stream lead, who is unable to be here today and sends his apologies. Just a couple of quick housekeeping things. If you can please keep your microphones on mute unless you're presenting. The flash talks will be timed and there will be a timer pop up. So we're trying to keep to time. There's a lot to get through. So I'll pass over to Zoe to take it away, please.
Thanks, Megan. Today, I will provide an overview of the projects that we do under NCIC surveillance stream, which focus on improving the infection surveillance among the immunocompromised hosts, an area with significant challenges and also unmet need. So early identifications of infections in ICH patients in the setting of new cancer risk and therapy is critical. However, these infections are difficult to diagnose as it requires a combined considerations of risk factors, imaging, and microbiology testing. And therefore, systematic surveillance of these infections is seldom done outside the research setting. There are also an increasing need for appropriate infection data for monitoring and reporting purposes in the setting of changing epidemiology, as well as to monitor effectiveness of prophylactic strategies. And therefore, to address all these gaps, the overarching aim of the surveillance stream is to use data for surveillance of infection and infection syndrome in order to support the detection and improve infection care in ICH. Next slide, please. Thank you. So our previous work using hospital-coded data done by Dr. Jake Valentine has demonstrated that high burden on infection in cancer population. So building on the existing collaboration with NCIC, our team also has successfully conducted several multi-center studies in Australia and New Zealand on invasive aspergillosis, non-aspergillus mold, and cryptococcus infection. And also we have the recently launched Candidemia study led by Dr. Abby Douglas. So the work by Dr. Xiaoyan Teo and Dr. Julian has provided important epidemiological insight on these fungal infections and has been published in journals such as Lancet and also CID. At the Parkview precinct, we have surveillance studies on invasive mold and respiratory viral infections, as well as point prevalence study on healthcare-associated and opportunistic infection. And just last week, the INTERACT study, which is the first survey on infection prevention and surveillance practice in the Australasian setting, has been published online in the American Journal of Infection Control. And the key findings suggested that practice standardization could reduce preventable infection in cancer and transplant patients. So there are several exciting, ongoing, and new study in progress. And this study apply a wide range of innovative approaches, including the evaluations of clinical and immunological signature as an indicator of post-infection frailty, genomic surveillance, applying AI for surveillance of infection in cancer patients, as well as novel digital phenotyping to identify immune-related colitis led by Dr. Jasmine Tang. So in all, these studies will aim to enhance the infection surveillance, as well as to inform clinical pathway and policy for improved patient care and outcome. So in the next slides, I'm going to introduce the Einstein study led by Associate Professor Leon Wolf. So recognizing the challenges of manually collecting data, we do need an enhanced infection surveillance system to actually identify the patients with targeted infections, minimizing the time spent for surveillance activities. And therefore, the aim of the Einstein study is to develop and validate an automated surveillance system in heme patients, where we extract and transform the data from EMR, including and combine the patient data, including like microbiology, histopathology, imaging, as well as drug prescribing, in developing the algorithm to detect infection episode using natural language processing and machine learning. So the NLP work led by Dr. Lauda have shown that both cytology and histopath reports can be automatically analyzed to detect IFI. So ultimately, what we want is to have a clinical portal where the clinician can actually access and log in to review the infection episode, as well as to monitor the infection rate over time. So under the Einstein umbrella, we have IFI, we have IFISH, which is led by Anna Kanina to detect IFI episode. And for the viral and bacterial module, we have we would like to develop a module to detect CMV and Staph aureus infections. So I hope I do give some context to everyone, like what we do under the NCIC surveillance stream. And after that, each of us will take you through to individual study in more details. Thank you.
Oh, fantastic. Thank you, Zoe. That's great scene setting. So next up, we're actually going to start with our first of our flash talks, and our first presenter is Anna.
Megan. So I'm going to talk about smarter surveillance of invasive fungal infection and using AI and technology to improve or enhance this process. So I think Monica sort of touched on a lot of why surveillance is important and why it matters. So it's really important that we're able to detect infection outbreaks as early as they do occur so that we can act on those outbreaks as they're occurring. We want to be able to spot emerging infection trends, particularly for new cancer therapies as they're being developed. You know, infection trends may not be identified as easily during clinical studies because of the narrow patient population. So in practice, we want to be able to spot infection trends as they're occurring. We also want to be able to monitor the impact of our prevention and our stewardship efforts as we're implementing them. And eventually, we want to be able to benchmark between different facilities to understand, you know, do we have a higher rate of infection than other hospitals? Or what are we doing? What could we be doing differently? So currently it's a very manual process. It's very time consuming, it's labour intensive. It's quite complex because you're needing to look at a lot of different things in the patient's record. You're needing to look at their risk factors, their imaging, their histopathology, their microbiology, their prescribing. It takes a lot of work to come up with a confirmation of a diagnosis. And you can't simply go to the lab and say, give me all of your patients with fungal infection, because there's no easily identifiable lab prompt that is consistently available for all patients. And this manual process is prone to human error. And in reality, it only happens sort of every now and then when we have dedicated studies, as Zoe did describe. We have had quite a few dedicated epidemiological studies, but they're not continuous and they're not timely. So our solution is to develop an automated system to extract data from the electronic medical record, to apply various things such as natural language processing to text reports, particularly histopathology and imaging reports, to find those reports that are suggestive of fungal infection. We then have algorithms to find microbiology results that are suggestive of fungal infection as well. We bring that all together. Eventually, we'll have a clinician web application that will allow clinicians to review that, and that should be ready by the end of this year.
Thank you, thank you, Anna. Next, we have back to Zoe.
Thanks, Megan. So I'm currently working on the CMV module for the Einstein study together with the team. So as we all know that CMV infection are associated with substantial mortality, especially in the stem cell transplant patients. Weekly monitoring of viral load is manually done and labor intensive, as we need to pull data from various sources, including EMR. So we are aimed to develop and validate an automated system to enhance the CMV infection monitoring process. And to do this, we have started the co-design process with the potential user from hematology, ID, and pharmacy. We adopted design thinking framework, which consisted of 5 major steps. So first, Sri and I have conducted several observational sessions to observe how the potential user currently performing CMV infection using the existing method. Then we conducted focus group to understand their current limitation and to explore their ideal experience with CMV monitoring. And then we actually organized and prioritized the user need and translated them into a design. And currently we at the prototype phase, where we are about to gather the open feedback from the potential user. Lastly, we would like to test and evaluate the usability of this CMV module. So we hope that with this CMV module, we can streamline the process and optimize the CMV infection management, which can then translate to a better patient care. Thank you.
Wonderful. Thank you, Zoe. Next up is Zanina.
Thank you, Zoe. So just continuing on from the previous slide, to better understand end user needs in terms of CMV infection monitoring and surveillance, we conducted a qualitative study recruiting healthcare practitioners within Victoria and New South Wales. Our participant group included hematologists, ID physicians, and pharmacists. Data was collected using focus group interviews and analyzed in vivo using thematic analysis. We identified in total 5 major themes and 17 minor themes. The major ones are listed here on this slide. And these included current practices and system limitations, which describes existing protocols and identifies operational and diagnostic challenges in CMV management. B, clinical data inputs informing CMV decision making, which outlines the types of clinical and laboratory information essential for CMV risk assessment and management. C, features and functionality of a proposed new system. So this summarizes the functionalities and interface expectations for a redesigned CMV monitoring system. D, implementation considerations that identifies factors influencing adoption, including user perceptions, workflow integration, and data validity. And finally, anticipated benefits on patient care and outcome that explores the anticipated effects on care delivery, safety, efficiency, and broader system applicability. Thank you.
Thank you, Zanina. Our next talker is actually a recording.
My work focuses on immune-related colitis, which is a type of immune-related adverse event affecting patients treated with immune checkpoint inhibitors for their solid cancers. IR colitis is increasingly important and its surveillance necessary as it causes significant morbidity in this group of at-risk patients. IR colitis affects up to 50% of checkpoint inhibitor-treated patients, and in moderate to severe cases of IR colitis, the patient cancer care journey is complicated by the need for immunosuppression, such as steroids and infliximab, lab tests, imaging, colonoscopy, and hospitalization. IR colitis-related mortality is reported at 1.8%. Real-world surveillance of IR colitis and downstream research is hampered in part by case-finding difficulties. This clinical entity is not encoded by the ICD coding system, and there is no single clinically validated biomarker that represents IR colitis. Using EMR data and leveraging established data science methods, we have developed a digital phenotype for IR colitis. This tool can be used to form the basis for longitudinal surveillance and propel further real-world research in IR colitis, such as process mining in the future. The digital phenotype that we've developed uses expert-derived features in the diagnostic workup and treatment data domains, as depicted in the figure. Thank you.
Thank you, Jasmine's recording. Next, we have Xiaoyan Teo.
So cancer patients are at risk of invasive mold infections, and even more so in the setting of environmental contamination, such as major construction work within the vicinity of the hospital. Effective surveillance and diagnostic approach are a very important part of mitigation strategies to prevent these mold infections, but this is currently lacking in Australia. So to better understand the complex epidemiology and the science behind environmental contamination contributing to these mold infections, as part of my PhD, I conducted an Australasian multi-center in-depth clinical epidemiologic evaluation of invasive aspergillosis and found that these invasive infections could also occur in patients without the traditional heme risk factor, such as those with solid organ cancer or even those without immunosuppression. This is then followed by the Parkville precinct-wide prospective surveillance of mold infections during the Metro Tunnel project, and we now have 7 years' worth of data to work on. I then performed a review to study the role and utility of different types of genomics analysis, such as whole genome sequencing, in investigation of healthcare-associated mold infections. And the final project is the CRISP-BAL study, which is an exploratory project to employ new and improved molecular methods to improve diagnosis of hematological patients with lung infiltrates. Because when we have good diagnostic tools, we'll be able to pinpoint what sort of infections the patients have, and it will help tremendously with the surveillance process. And hopefully by understanding these complex epidemiology and environmental exposure, we'll be able to come up with effective surveillance strategy in the near future. And enhanced diagnostic platform forms just part of this surveillance strategy. Thank you.
Thank you, Xiaoyan. Next speaker, back to Zoe, our amazing stream manager, postdoc, project manager extraordinaire.
Thanks, Megan, for the introductions. Today, I would like to share with you the findings that we have from the non-aspergillus mold infections in Australia and New Zealand, focusing on the epidemiology and the clinical outcomes. So the incidence of NAM infection is increasing, and under-recognition of these infections are associated with high mortality. The previous study may not reflect the current epidemiology, given the expansions of patient group at risk, as well as the increased prevalence of emerging NAM species. So we conducted a 21-center retrospective study across Australia and New Zealand, and there were a total of 421 proven and probable NAM infection diagnosed from 2016 to 2023 were included after adjudication. There are several key findings, including significant shift in species distributions, where we noted there's an increased contributions of dermatitious mold to our NAM, to the NAM cases in our current study, which is in contrast to the previous study where mucorales were predominated. Lomentospora polyficans was the most common cause of breakthrough infection, despite with posaconazole prophylaxis. Worst outcome was noted in Lomentospora infections with the highest mortality and treatment failure rate, followed by mucorales. So this study will provide a comprehensive understanding evolving of NAM epidemiology and the treatment response of each NAM infections, which are critical to optimize the management of NAM infection. Thank you.
Wonderful. Thank you, Zoe. Priya is up next.
Thanks very much, Megan. So my projects are on infection prevention and surveillance in the Australasian cancer and transplant populations, really tie into the overall theme of the stream. The problem, as already expressed, is that cancer and transplant patients are vulnerable to infection, which can lead to significant critical illness and deaths. And as pointed out, there is a significant gap in that strategies for the monitoring and prevention of infection differ across Australasia. And in this space, national and international guidance is limited. In terms of our methods, Zoe has already highlighted that we have conducted a survey termed Interact of healthcare workers to understand how Australasian hospitals currently track and prevent infection. And this map shows all of the responses received from all Australian states, the Northern Territory and New Zealand, and the paper published describes significant heterogeneity across various domains in terms of infection prevention and infection surveillance across all of these areas. And we are now also currently undertaking a study called Prosper across Australia to see which infections, both healthcare associated and opportunistic infections, are most common and relevant in the cancer and transplant population to inform and prioritise our future work. And our hope is that we will use this data to help guide specialised national recommendations in infection prevention and surveillance for our cancer and transplant population. And our belief is that shared prevention and monitoring strategies will help reduce preventable infection for this really vulnerable cohort. Thank you.
Amazing. Thank you, Priya. Next, we have Dr. Alice Liu.
Hi, thanks, Megan. So my name's Alice. I'm the clinical research fellow with the unit at the moment and intending to embark on a PhD next year. I just thought I'd share one of the projects that will form that, which I've dubbed FLARE. And that's really because we know that there have been lots of advances in our treatment of hematological malignancies in particular, and we're being very good at improving the mortality outcomes from it. But of course, these patients are still at risk of severe infection and more importantly, morbidity from that infection. So what we're trying to achieve with this study is to look at who is most susceptible to developing frailty as a surrogate measure of morbidity here, and whether or not there are clinical and biomarkers that we can use to identify these patients and monitor them ongoing. So for this study, it will be a prospective multi-centre observational study using these two clinical scales that are already validated in a geriatric population. So the clinical frailty scale and this Rockwood-Minsky frailty index, to see whether they may be applicable in our vulnerable populations, as well as accompanying this with some additional biomarker assessment by looking at blood tests assessing for lymphocyte subsets and self-surface markers. The hope being that we can get some longitudinal sort of change and to identify these patients at an early time point. And ultimately, the aim would be to establish some clinical and immunological signatures that can help improve survivorship outcomes for patients with hematological cancer.
Wonderful. Thanks, Alice. Next, we have Ka Yi Yong.
Hi everyone, I'm Kai. I'm the RA with NCIC. As many have mentioned previously, the infection, or in this case particularly respiratory viral infections, cause significant morbidity and mortality in hematological transplant recipients, and allergenic transplant recipients are at high risk for severe infections. So we wanted to assess the impact of respiratory viral infections on transplant care, and to evaluate the need for delay in transplant if one is infected with respiratory viral infection. So IRVIN is a retrospective data collection study capturing all confirmed respiratory viral infections in allergenic transplant recipient between 2018 and 2023 at the Royal Melbourne Hospital. During this study period, we identified a total of 324 respiratory viral episodes from 175 allotransplant patients, and we found that respiratory viral infections are prevalent before and after stem cell infusion, typically within 1 year transplant period. So rhinovirus was the most common virus detected, followed by coronavirus and RSV. We also found that despite having COVID lockdown restrictions between 2020 and 21, rhinovirus continued to circulate within this immune-compromised population. And when compared to pre-transplant viral infections, we found that post-transplant infections were associated with an increased need in oxygen requirement, ICU admission, and a lower survival rate at 90 days. We hope that our results will help us understand the risk factors and the clinical impact of respiratory viral infections that will help improve management strategies during transplant care. Thank you.
Thank you, Kai. Next. Oops, that's the end of our first section there with the surveillance stream, which is an amazing breadth of projects and some really exciting data coming out. So thank you to everyone in the surveillance stream. Next, we have a short interlude. We're going to hear from our clinical trials team lead, Rachel Wollstonecroft, and our lab manager, Sarika Tennakoon, on the NCIC platform and what we can offer to the Institute and the precinct in a wider sense. Thank you, Rachel.
Hi everybody, I'm delighted to take this opportunity to share the important and multifaceted work of our incredible clinical trials team, a collaborative multidisciplinary group committed to supporting our high quality, ethically sound and scientifically rigorous research we do every day. And while I'm specifically presenting our team here today, we would like to acknowledge the skill, expertise and talent of our clinical research colleagues at other departments and institutes who support the NCIC. We are fortunate to have a dedicated team that includes a research nurse manager, research nurses, research assistants, and a research support officer and an intern, all working closely with our investigators to help navigate the complex landscape of clinical trials. Uniquely, our team includes a dedicated research fellow who brings additional clinical and academic expertise to our project's oversight and delivery. We work with a broad spectrum of researchers, from experienced investigators to those who are new to clinical research. We provide practical, regulatory and operational support throughout the research lifecycle. Our team has significant experience coordinating phase 2 to phase 4 studies, including large multi-centre trials that are commercially sponsored, academically led or investigator initiated. Next slide, thanks. Apologies. A critical part of our role involves sponsorship, ethics and governance. This includes ensuring that all trials are underpinned by appropriate ethical approvals and adhere strictly to the institutional, national and international regulatory frameworks. We provide guidance and submission support to streamline the ethics and governance processes, making sure that our projects and trials are compliant, robust and ready to commence without unnecessary delays. We contribute to the preparation and feasibility of new studies, whether initiated by industry or by our own investigators, helping to ensure a smooth study startup and coordination. Our team negotiates and manages financial and legal agreements, ensuring that all parties are protected and that these resources are used efficiently. We ensure study teams have access to good clinical practice, GCP training, and help researchers navigate the fairly complex mandatory training landscape and build capability across our partner institutions, reinforcing our commitment to research integrity, accountability, and excellence in human research. Our team plays a central role in data management and documentation, from the design and deployment of standardised data collection tools to custom REDCap builds. We support researchers in capturing accurate and high quality data. Using tools like REDCap and platforms like Teams, ACTech and SiteDocs, we can enable collaborative, transparent and secure trial coordination. Our trials framework ensures consistency in trial conduct, helping teams move efficiently through the key milestones of research, from startup through to archiving, ensuring that study records are properly stored and remain accessible for audits, analysis and future reference. At its core, our team is here to provide quiet, sometimes consistent support, and to reduce the burden on investigators and make research more accessible and sustainable. We're really proud of the relationships we've built across the departments and the disciplines and institutions, and we value that collaborative spirit that underpins everything we do. We want to thank all our investigators, clinicians and colleagues who continue to engage and trust in our team, and your partnership is essential to our shared goal of advancing the patient care through meaningful and ethical research. Thank you.
Thanks, Rachel. Hopefully we've got Sarika ready to talk about the NCIC lab.
Hi, everyone. I'm Sarika, and together with Emily, we make up the NCIC laboratory, and we sit within the TRC of Peter Mac within Cluster 8 on level 12 within a PC2 compliant facility. So our lab services include biobanking of samples. Some of them are listed here. They're not exclusive, and some of the biobanks that are available currently are also listed here. We are able to cryogenically store and transport biospecimens from a range of temperatures from -20 up until liquid nitrogen. We have our own in-house dry ice supply, which might be appealing to some who do lab research. We're also authorized shippers, and we have completed the safe transport of infectious substances by air course, so we can always assist anyone who wishes to transport samples locally and internationally. We have access to electronic lab archives and e-specimen storage repositories, which is Freezer Pro, which is Peter Mac's preferred sample archiving liquid nitrogen facility. Next slide, please. Our research-specific support includes internal and external groups. We could support them with sample processing, storage, and transport, as well as from lab budget and lab manual preparation through to procurement and setting up an assay. We manage access to stored biobanks following an application through the internal NCIC Biospecimen Review Committee. We can also help assay development and validation, such as ELISAs, DNA extractions, and PCR, as well as provide training for lab sample processing, ELISAs, and PCR. And they have put in a little table to show you some of the samples we have collected so far. And if anyone wants to access them or build a collaboration, please feel free to reach out and we will be more than happy to help. Thank you.
Thank you so much, guys. That's a really great